stress the brain and you load in cortisol or an infection or a toxin or trauma, traumatic brain injury, and we start to excite and even injure the neurons of the brain, the brain has this amazing ability to sense this and adapt to those stressors. But there are two routes that the brain can go down when we see volume loss. You can ask yourself the question, is it just merely scarification and atrophy? Did we just fully, informally, and totally injure the brain? And it's not recoverable. That's one version of volume loss, atrophy. Another version, which is fascinating, is called dendritic retraction, where the neurons are getting injured and they sense this and they start to retract in on themselves. And we lose the budding and branching and volume associated with the beautiful dendrite. It's almost as if the neurons hibernate. And guess what happens? If dendritic retraction is occurring and the neurons are changing their shape and retreating from the stressor, if you remove the stressor, the neurons can rebud and regrow and rebloom. That the brain has a mechanism to heal itself. Now, we don't know. There's no great way to know when you do specialized brain scans, and I do specialized brain scans, to tell where there are areas of volume loss and nuclear atrophy. Is it true atrophy, or is it dendritic retraction? But the hope and the promise is there that you can potentially fix the brain and see those areas regrow again. And it's happening in the hippocampus in the CA1 and CA3 regions. We see changes in neuronal morphology with dendritic retraction due to unregulated glucocorticoid release, meaning stress, with localized oxidative stress, neuroexcitation, and loss of counterregulatory control. So, neurons need to protect themselves from the excitotoxic effect of glutamate. So, we have glutamate receptors in the brain. This is the excitotoxic pathways that it lights the brain up, which is good, but over time it can be somewhat destructive. So we see loss of their surface input. So the brain has different ways of reducing the impact of stress on the brain. So we see this in terms of, this kind of complex of events happening simultaneously. So when the person is under stress and cortisol levels are high, we have accelerated neurodegeneration. We see hippocampal atrophy, loss of regulation of the HPA axis, memory and cognitive deficits, and changes in the prefrontal cortex, amygdala, locus coeruleus, and potentially loss of adult neurogenesis. That when you injure the brain and you stress the brain, this can interfere with the brain's ability to heal and repair. So all of this is happening under high states of stress. We can't not have this happen. It's just how we're built. This is the reality. So you can take out the hippocampus. And I always think about how stress really affects that brain-immune connection. And what is the stance of the immune system? And then this is fascinating. When you look at the literature on chronic stress and all the illnesses that go along with, quote, chronic stress, and then you look at chronic inflammation and all the illnesses that go along with chronic inflammation, they're basically the same. They're essentially two sides of the same coin. And now it should make more sense. In addition to that, not only does stress or cortisol have a direct effect on the immune system, but there's another way we can talk to the immune system through the stress response, and it's with the autonomic nervous system. So what happens is when people are under stress, their heart rate speeds up, and we have a large release of catecholamines, epinephrine, norepinephrine. And if that state persists, there are binding sites on immune cells for epinephrine and norepinephrine, which upregulate the immune system. And we can tell if a person is under chronic stress if they have a higher than normal baseline heart rate, so a higher than normal resting heart rate, which also tends to correlate with as the heart rate speeds up, the timing between beats becomes more predictable, almost like a metronome. And the faster the heart goes, the more predictable the timing between beats. Conversely, when people are under states of relaxation and the parasympathetic nervous system takes over, the heart rate slows down and there's more irregularity in the timing between beats. And this notion has been observed for many, many, many years, looking just at EKGs, that when we do breathing techniques and contemplative practices and we're under deep states of relaxation and what we call internal coherence, we have a high heart rate variability, meaning unpredictability between timing of beats, and a slower heart rate overall. And you can measure this. You've probably heard this term, heart rate variability. And the greater the variability, typically speaking, the less stress the person is experiencing. But what is that really a proxy measure for? Some of you probably heard this term, heart rate variability. What does it really mean? It means that if you have a patient who has low heart rate variability and high resting heart rate, what are they really doing? They're just triggering their immune system. That by definition, those patients have higher baseline levels of inflammation. They have higher CRP. And what was the first disease that was linked to low heart rate variability, to higher states of chronic stress? Heart disease. And what was happening was that systemic inflammation was injuring the blood vessels and reducing endothelial function and leading to plaquing and buildup of atherosclerosis and ultimately MI. So heart rate variability, believe it or not, is merely just a proxy measure for systemic inflammation, and that systemic inflammation is what drives all the illnesses associated with low heart rate variability. Heart disease being the model. It's very simple. When you understand these concepts, it should all start to make sense. And so you can drive an inflammatory process by having low cortisol and a low heart rate variability. They have a big fire burning in their body. And who knows? What's the tissue? What's the organ system? What is the illness that will arise as a result? For some, it's the heart. For some, it's the brain. For others, it's the gut. Some, it's the immune system. Or some combination of those things. So here we have that model. When cortisol levels are high, Th2 dominance, allergies, asthma, atopic illnesses. When cortisol levels are low, Th1 dominance, a predisposition towards autoimmunity. And T regulatory cells are very important to help balance how the immune system is responding on the adaptive side. Turns out a lot of my research is in this upper quadrant over here on the left, which are Th17 cells producing TGF-beta1. And that's a primary actor for inflammation. Not a huge part of this story, but a part of the story. So here's those microglial cells. These are those macrophages of the brain, these specialized immune cells that we didn't even really know the brain had an immune system for a long time, but now we do. This notion of that brain on fire phenomenon, it's kind of out there now, and we sort of respect it as, we didn't understand that inflammation drives neurodevelopmental disorders, mood disorders, neurodegeneration, that it stands at the center of a variety of neurologic processes, and that we can trigger these microglial cells just by stress alone, but also chemicals and toxins and traumatic brain injury and all sorts of things. And when we turn on a microglial cell, they start releasing neurotoxic factors which begin to damage local neurons. And when those neurons die, they then activate more microglial cells, so you get this sort of self-perpetuating event. Now, interestingly, and I think it's worth mentioning just because for clinical reasons, microglial cells have basically two different phenotypes, as we call them. There's the M1 phenotype and the M2 phenotype. So M2 phenotype for a microglial cell, a macrophage, is one that's actually pretty sedate. And it's functioning in a rest and repair mode. It's looking to clean up debris in the tissues. But when you trigger a microglial cell, it will shift to an M1 phenotype. And now it becomes a thug. And it wants to beat stuff up, and it can and it will. And it'll cause a lot of local tissue destruction in its effort to get rid of whatever threat is around. So when you have an M1 macrophage or an M1 microglial cell, it's squirting out a bunch of inflammation. And microglial cells shift back and forth between M2 and M1. So when you have a threat, an immune threat, you have M1 macrophages and microglial cells rushing to the scene of the crime. You have neutrophils rushing to the scene of the crime. We have activation of the complement system in the blood. We have natural killer cells that start to surveil the tissue. But when all that's over, and there's just debris and destruction, those microglial cells and macrophages shift back to M2. And now they become the cleanup crew. They're anti-inflammatory, they're reparative, they start producing fibroblasts and start producing collagen and elastin. It's amazing, they shift. Now it turns out Harvard figured out how to shift them back and forth. And there's a variety of compounds that do that. And they're called resolvins and protectins and mucins and lipoxins. And resolvins as a category are great to turning off inflammation. And I'm saying all this because, believe it or not, we have treatments where you can give patients resolvins and turn off that neuroinflammation. It's like a lock and key. So resolvins are these small lipid compounds that bind to G protein couple receptors on the inside of a macrophage. And they shift it from M1 to M2, from a thug back to the cleanup crew. It turns out resolvins and protectins occur naturally in fish oil, especially small fish, anchovies, sardines. So we think probably some of the mix of positive and negative fish oil studies is because we never really knew how much resolvins we were giving patients in the fish oil. That some had high amounts and some had none. And maybe that's part of the discrepancy in fish oil studies. Now, companies typically wouldn't check for resolvin levels in fish oil. And all of that was dependent on what the fish ate. If the fish had a healthy diet of algae, high levels of resolvins. If it was farm raised and fed corn, no resolvins. So there are products on the market that are basically oral resolvins. And you can give resolvins to patients now to see if you can turn off their inflammation. If you think about it, most of what we do treatment-wise is upstream, giving anti-inflammatories to blunt the effects of microglial cells or macrophages or the inflammatory cascade. This is the only mechanism we know of and that we have to literally turn off inflammation downstream. It's fascinating. So we're learning more about how the immune system turns on and off. We never knew how the immune system turns off. Well, they turn off because of these lipid mediators, these resolvins and protectins, and you can give them in your practice now to turn off inflammation. And what you're really doing is transitioning those macrophages from M1 to M2. So you should know what you're doing when you do that. Now here's a model. Here's a model of how stress affects the gut. And it's very similar. So we should see this. We should see consistency across body systems within this narrative. So here we have on the far left an irritable bowel patient. And we know in irritable bowel there's maybe a little bit of immune function going on in the colonic tissue, but not a lot. We know it's kind of mostly functional, but interestingly, they already knew when cortisol levels were high, there's a predominance of Th2 in the gut. So the gut is a little leaky, it's a little histaminic, so we have high tryptase and histamine, and we see a blunting of Th1. Now conversely, What do we see in the gut in inflammatory bowel disease patients? Well, by definition, they have chronic inflammation. So like a teeter-totter, when inflammation is high, cortisol levels tend to be blunted, so that's why you have a parentheses around the cortisol. And there's a shift to Th1, higher levels of IL-1 beta and IL-6 and TNF-alpha and CRP. Makes sense. That's the stance in the gut. Now, here's the interesting thing. What if I take an irritable bowel patient and their Th2 in the gut with high cortisol, and I flatten their cortisol curve? I give them a lot of stress. Now their inflammation levels go up, and there's a shift from Th2 to Th1. And that's exactly what we see in the gut. That you can push an irritable bowel patient down the path to becoming more systemically inflamed and start to look like an inflammatory bowel disease patient when you flatten their cortisol curve. And that's what this model showed. That there are much higher rates of inflammation, Th1 dominance, in the gut when you took an irritable bowel patient and you flatten their cortisol curve. So it happens everywhere simultaneously. Now, if that weren't bad enough, when we have stress, we also trigger enzymes in the digestive tract called Andolamines. And Andolamines are a very interesting enzyme. They do all sorts of things for us. But one of the things they do is they help regulate the production of serotonin in the gut. Now we know 95% of serotonin is produced in the digestive tract. But if I stress an individual and I turn on Andolamines, they strip tryptophan away from serotonin production, and they push tryptophan down the kynurenine pathway. And there's a preferential production of quinolinates, or quinolinic acid. And see, these quinolinates, when they build up in the system, they have a direct injurious effect to the brain. They cause neuroexcitation, and they've been linked with depression. So when we excite the gut and we cause inflammation and stress in the gut, we typically have an overproduction of quinolinates, which can lead to depression. So this is called the neurodegeneration hypothesis of depression, that as we strain the gut, we can induce a mood disorder. So stress has an effect here as well. So once we flatten our cortisol curve, we have systemic inflammation, we have microglial activation, serotonin degradation, and non-specific symptoms of sickness. Now I'm going to spin your brain one more time. So if this weren't enough, listen to this one carefully. A new view on hypocortisolism. Raisin and Miller assume that prolonged or repeated exposure to immune stimuli might predispose an individual to reduced glucocorticoid signaling as a means of freeing bodily defenses from inhibitory control in the face of an ongoing infectious threat. So that's a bunch of gobbledygook. You're probably tired and like, I don't know what he just said. What he just said was the body sees an infectious threat, and to liberate the immune system, guess what it does? It turns down cortisol on purpose. That it's an adaptive response to immune stimuli. Thus, an enhanced release may be beneficial for health and survival. So, it's good for you. Most strikingly, the demonstration of a low allostatic load index in hypocortisolemic subjects suggests that a downregulation of the HPA axis in chronically stressed subjects protects those subjects against the harmful effects of a high allostatic load index. That low cortisol can be an adaptation to an immune threat and specifically adaptive. How many times have you had a patient come to your practice with low cortisol and you go, yay, your body's doing what it's supposed to do, I'm not going to do anything? How many times have you done that? Zero. Or how many times you said, you've got an immune threat. Your immune system is upregulated against something. You've got low cortisol for a reason, but it's not on the cortisol side. It's on the immune side. And did you go fishing for that clinically? Or did you say, oh, I'm going to do everything I can to raise your cortisol? Which in turn does the bugs a favor. Because if you start raising these patients' cortisol, what are you doing by definition? You're suppressing their immune system. You're blunting the freeing of bodily defenses against whatever immune threat is there. I see this all the time in my mold patients. They tend to have low cortisol. They're in a pro-inflammatory state. All the time. I don't spend any time trying to raise their cortisol. I deal with the immune threat. We clean up the home. We remediate. And we do special things to try and regulate the immune system. And guess what happens? Cortisol levels come up like magic. I don't chase the cortisol. All of these things have these interrelationships, and you have to ask yourself the question, did they get to a low cortisol state because they were stressed and they fried their brain? Did they get to a low cortisol state because they have an immune threat? How did they get here? But in both cases, in both models, the last thing you want to do is raise cortisol. So we have a couple models, the developmental model, so we fry the brain, or immune-mediated model. And prolonged cortisol production is neurotoxic, and there's a reciprocal relationship between the immune system and the HPA axis. So, hypocortisolism may be an adaptive mechanism to protect the nervous system. Whoa. You should be freaking out a little bit now if you haven't heard any of this, right? Like, I gotta rethink this whole thing. I'm gonna open a food truck instead. So central mechanisms of hypocortisolism, we see reduced biosynthesis, hippocampal atrophy, we've talked about all of this. And there's global consequences in just about every system in the body, with immune system dysfunction, inadequate immune trafficking, inability to defend against pathogens, inadequate leukocyte trafficking, and elevation of immune mediators. So the body becomes inflamed and predisposed to autoimmune conditions. The heart is affected as well. We know this with chronic inflammation, damages the blood vessels, leads to endothelial dysfunction, predisposes to hypertension, plaquing of the arteries, and ultimately MI and congestive heart failure. We see the same thing in diabetes. Now this is interesting. When you're under states of stress and cortisol levels go high, and you're fighting the tiger, or you're running up a tree, or you're doing something to deal with that stressor, the body assumes it's going to be pretty physical, right? It doesn't make that distinction. So we see these metabolic shifts, and yes, cortisol levels go up, but what does cortisol do? To make sure that you have plenty of energy available to your muscles and tissues to deal with the threat, it induces a relative insulin resistance. And people who have chronic stress have higher baseline levels of blood sugar because they can induce a more permanent insulin resistance. So we always have to think about that kind of balance. Now, what about outcome studies? What about outcome studies? So, many of you have probably seen cortisol measurements, and we measure cortisol throughout the day. And what's interesting is when you actually look at the literature on how do we know the pattern is injured, how do we know that it's abnormal? Well, the research groups don't do what we do. They actually do what are called regression analyses and use statistical modeling to measure the slope of the cortisol curve. And what they find is the flatter the slope, the greater the injury to the stress response and the greater risk for outcomes. And they measure this by typically quartiles or quintiles. So here's the cardio study in 2006, just one of many, 718 black and white middle-aged men, They did 6 salivary cortisol samples, and what they showed is that the cortisol slope in the flattest quartile had the highest coronary calcium score index. Makes sense. What does the body do when its tissues are inflamed? What does it lay down? Calcium. So what they showed is that the flatter the slope, the greater the inflammation, the greater the coronary calcium score. And we see this over and over and over. This is another one of these kind of permanent consistencies in the literature. So what do people experience in terms of, hypocortisolism? They're kind of the big 3. It's fatigue, it's pain, and it's stress sensitivity, that even small amounts of stress will feel overwhelming for them. And of course, they've been linked to chronic fatigue and fibromyalgia and PTSD. So let's look at some patterns. Here's a normal pattern. High in the morning, get out of bed, get going, and lower throughout the rest of the day. So cortisol levels start to rise before you get up in the morning to wake up the brain, wake up the body, and begin to deal with the stress of the day. That in fact, the most stressful thing under normal circumstances that the body thinks it goes through is waking up and just thinking about the day, right? And then it goes down over the course of the day, but then if you have a stressor, cortisol goes up and it comes down. But this is a normal curve. This is what we say is a preserved diurnal pattern. Nice regression curve. Fine. Here we have someone, this patient of mine, who is clearly under high states of stress. She has done 2 things. She was the head of a department at the University of Michigan, and she had done 2 things. She had high cortisol output, right? So she's treatment-sensitive depression, hypervigilant, wired and tired, suppressed immune system, Th2 dominant, frying her brain, catabolizing tissues in her body, right? And she's flattened her curve. So she's even worse off. High and flat. You can have high and diurnal, which is better, still preserved, but you can have high and flat. She's high and flat. Here's someone who's starting to compensate, and the brain and the body is saying, okay, enough is enough. I'm starting to reduce the allostatic load, and this is where people can end up, low and flat. Fully released immune system, Th1 dominant, activated microglial cells, you fried your brain, you probably have a leaky gut, you're leaning towards autoimmunity, and if you have any concurrent illness like diabetes, heart disease, cancer, you're gonna have poor outcomes. You'll have worse outcomes. Why? Mostly likely because of the chronically elevated IL-6 and underlying inflammation. Or you can say, no, immune-mediated model. There's an immune threat here. They're dealing with some sort of exposure that I need to uncover. Either way, we know that they are worse off than this, and certainly this. This is where I worry the most. And unfortunately, this is what I often see in my practice. So we know flattening of the cortisol curve is most predictive, it's most well studied, and low cortisol leads to intensified immune vigilance, elevated IL-6, and fatigue. So here we go, flattened cortisol rhythms in metastatic breast cancer patients. Breast cancer patients have worse outcomes when they flatten the cortisol curve. And we see this again, early metastases and mortality, early CHF and MI, and atherosclerosis, worsening glucose control. It's all over the research. So, how do I protect the brain? If this is one of the primary target organs, what do I do? Is there anything I can do? And part of it is just to be reassured that you can do something, that the brain has the ability to repair. And yes, there is this concept of adult neurogenesis, this notion that there's this intrinsic ability for neurons to go through a multi-step process and essentially end up with a fully mature neuron. That we go from basically a progenitor cell all the way up through a full dendrite. And it's possible. But there are mediators of this process. And some of those mediators are stress itself. So if you have ongoing stress, it can interfere with neurogenesis. Poor sleep will interfere with neurogenesis. And we know that there are glucocorticoid and NMDA receptors on those progenitor cells. So if you continue to excite that patient and then stress them, we'll see this lasting inhibition of adult neurogenesis, which can occur after an initial stressor despite later normalization of cortisol. So you can stop the brain's ability to heal and repair if they have ongoing stress and or if you have one major trauma. So here we're starting to build a model. Cortisol affects the brain. We have neuroexcitation, reduced neuroplasticity, and an imbalance between the sympathetic and parasympathetic nervous system vis-a-vis heart rate variability. We have a shifting immune system, either high or low, plus Th1, Th2 dominance, microglial or macrophage activation, and turning on of IL-6 and TNF-alpha, especially in low cortisol states, or conversely suppressed. And don't forget that you can catabolize other areas of the body, like the gut lining, so we can get gut permeability and elevated of Andolamines, leading to that further sensation of deep depression. What a mess. What a mess. This is all happening at once. So what are some things that you can do to help blunt this process? What are some tools in our toolkit that I think are worthwhile and interesting and effective? So there's philodendron and magnolia. It's a combination of two botanicals that have anti-anxiety and anti-stress properties. And interestingly, they've specifically been shown as a combination to lower high cortisol. And they do it very effectively. So it's a standardized extract. Whatever company sells this combination product, it's always going to be the same dosing, and it's one capsule 3 times a day of the standardized magnolia philodendron. It's a great product. And I use it all the time in my practice. And as much as I think it's kind of a natural antidepressant, you also have access to a natural anxiolytic, which is L-theanine. And it's a single amino acid from green tea. It was basically isolated 50 years ago now, and primarily studied in the setting of acute and chronic anxiety. And it's an analog of glutamine. So it's interesting. So it antagonizes NMDA receptors, it decreases neuroexcitation, it reduces the effects of catecholamines on the brain, it lowers blood pressure, it binds to GABA and dopamine receptors. So it's calming, but it improves focus at the same time. The thing I like about it is that it's not sedating. So it doesn't work like a benzo in that regard. And I use a ton of theanine. The nice thing too is that it's extremely safe. I mean, you could bathe in this stuff and it wouldn't hurt you, right? You can give it during the day.
What's the highest dose in use?
So the highest dose in use, the upper limit of safety, at least described in the US, is 1,200 milligrams daily. There is no upper limit of safety in Japan where it was first studied. In fact, they have not found a dose that would kill a rat. They just get more and more calm in the cage. You can use as much as you want. Your patient's going to run out of money before they run out of theanine. Okay? So, typical dosing, 200 to 400 milligrams several times a day. No known side effects. Now, what about the immune side? So, okay, here's a cool, couple interesting things for mood and stress. But what about that immune modulation? Now, if you recall, I had that one slide where it said Treg cells, Th1, Th2, Th17, T regulatory cells are what modulate and balance the immune system. And here we have potentially maybe the most widely studied natural compound in humans that you're not aware of. And it's called a plant sterolin. And it exists in a very specific ratio of 100 to 1 between sterols and sterolins. It was originally identified in Germany from pine bark. And it raises T regulatory cell activity and balances Th1, Th2. It is a very interesting compound. It has sort of unique activity. If you want to give it a corollary, maybe low-dose naltrexone, maybe 1,3,1,6 beta-glucans. but it has its own body of research, which I think is pretty extraordinary. So it modulates the immune system, it improves CD4 helper cells, it enhances natural killer cell activity, and it balances Th1, Th2. When patients are under stress and they're immune compromised, this is what I give them. If they want something to help them resist COVID, this is what I give them. If they have an autoimmune condition, this is what I give them. If they have allergies and asthma, this is what I give them. If I'm just worried about the strain on the immune system because they flatten their cortisol curve and they're chronically inflamed, this is what I give them. And it has this kind of ubiquitous effect and a wonderful balancing to the different arms of the immune system. And it knows what to do. So the standard dose for this is 2 capsules in the morning and 1 in the afternoon for 60 days, and then it's 1 capsule twice a day. You should probably ask me what it is.
What is it?
Hint. It's called ModuCare. ModuCare is developed by in Germany, but then sort of enhanced by Wakanaga. So ModuCare. It's very unique. ModuCare. 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 And then 1 cap twice a day. So 2 in the morning, 1 in the afternoon for 60 days, and then 1 cap twice a day thereafter. So ModuCare, there's only one company that makes it. ModuCare. Yes. I didn't invest in this. Actually, I think now there are 2 companies, Wakanaga and Thorne. I believe Thorne also sells ModuCare. But just look for ModuCare. ModuCare. All right, so then let's get a little fancier. What do we do about this fire in the brain? What do we do with these activated microglial cells and destruction to brain tissue and high cortisol? And oh my gosh, what a disaster. Well, got a call from the School of Pharmacy of Beijing a number of years ago, and they said, we have isolated something really special from Chinese ginseng. Now you should know, in Chinese ginseng, there are a family of what are called ginsenosides that we know are biologically active, and there's the RB line and the RG line. So there's RB1, RB2, RB3, RB4, there's RG1 and RG2 and RG3 and RG4 and so on and so forth. What they showed was that RG1 and RG3 had the most neuroprotective effects of any of the ginsenosides that they studied, and RG3 in particular has very potent antimicroglial effects in the brain. It reduces oxidative stress, and they said, this is a wonderful thing, but we don't know how to use it clinically. We can't get it into a delivery system. That makes sense. So they called us, and through our network, we found a way to get it into a nasal spray. A nasal spray. So RG3 is a triterpene saponin, called a ginsenoside, supports neurotransmitter function, decreases excitotoxic and oxidative stress in neuronal cells of the brain, reduces damage, decreases or blunts microglial activation, and it's specifically been studied in the processes related to Parkinson's and Alzheimer's. It protects the hippocampus. In particular, protects the hippocampus. Now, stepping back from this idea, it all sort of makes sense. Ginseng, ashwagandha, rhodiola, maca, cordyceps. The list goes on, right? What are all these herbs called? What is this kind of category? They're called adaptogens, right? Why? Because they help you adapt to stress. Where do they all work? Do they work at the level of the adrenal? No. Where do they work?
Brain.
They work in the brain. They blunt the effects of cortisol on brain tissue. They reduce neuroexcitation. They modulate inflammation. They protect the hippocampus. That's what they all do. And they stimulate heat shock proteins and other things. But in general, they protect the brain. So every herbal tradition around the world, China, India, Japan, Southeast Asia, Eastern Europe, Western Europe, North America, they all had 1 or 2 herbs that rose to the top. as being considered magical. They're all adaptogens, and they all work in the brain. Now, because they're complex agents, yes, rhodiola has a little more cardiotonic effects, and ashwagandha has a little bit more thyroid effects, and cordyceps has a little more kidney effects, but in general, the way they work, the reason why they make people feel better is they affect the brain. And so what the School of Pharmacy in Beijing did is they kind of figured out what are the isolated ingredients that particularly protect the brain. They said RG3, makes sense. So decreases oxidative stress, decreases inflammation, increases survival rate of neurons, and attenuates those NMDA excitatory receptors. So you can do this as an oral or a nasal spray. And I do it as a nasal spray, 2 milligrams of a nasal spray. This is compounded. So every PCCA pharmacy knows how to make RG3 into a nasal spray. If you really want to protect your patient's brain from ongoing stress, and I mean every type, concussion, stroke, Alzheimer's, Parkinson's, you name it, RG3. I can tell you, there are many Navy SEALs walking the face of this earth who've got a bottle of RG3 in their bag. I can tell you, most, not all, but most of the current living Pro Football Hall of Fame football players are taking RG3. I've had the privilege, I take care of all the Pro Football Hall of Fame football players. We have a whole program for them. And it started because of this, literally. We began treating them in onesies and twosies. They couldn't believe how much better their brains felt, even years after retiring. And word spread. The RG3 alone, no, we don't see any contraindications with that. Now usually, so I'm going to get back to that in a second, but we typically combine it with nicotinamide riboside. So in the early 2000s, Harvard was doing wonderful research looking at what really nourishes neurons, what preserves neurons over time and protects against neurodegeneration, like Alzheimer's. And they found that there's this critical substance, NAD. NAD. And I know you've probably been exposed to this, but basically it's brain food, right? It's wonderful for neurons, and it influences the sirtuin pathway, and it's anti-inflammatory, and it creates longevity with neurons. It's an amazing substance. But what is its direct precursor? Nicotinamide riboside. And nicotinamide is derived from vitamin B3. So you can take oral nicotinamide, but we put it into a nasal spray, and we combine it with the RG3. So now we have this kind of next generation adaptogen. So if you really want to get into the weeds with a patient and they're super sick and they flatten their cortisol curve and they've got all sorts of issues going on, I start to reach for these more potent tools. And the nicotinamide is wonderful. There's tons of research on nicotinamide. And again, you can do it orally. We put it in a nasal spray. We combine it with the RG3. Usually pharmacies will add B12, like a methylcobalamin, and that can be activating for some patients. So if they report when they start the nasal spray they can't sleep, take out the B12. That's the only side effect that we've seen. And I have witnessed some pretty extraordinary results with this nasal spray. I have a patient, 40 years old, stabbed in the chest with a chef's knife by his girlfriend. Eventually ended up in the hospital, had a 17-minute anoxic brain injury. His heart stopped for 17 minutes. Most humans do not survive a 17-minute anoxic brain injury. He was left in a vegetative state for 13 months, completely unresponsive, ventilator dependent, feeding tube, GJ, the whole thing, and ended up in a specialized long-term care facility in California. And through the grapevine, the family heard about some of the work that I was involved in, and they said, "Can you help our son?" And I said, 13 months vegetative state anoxic brain injury, the odds of him waking up are almost zero when you just look at the actuarial tables. I said, well, I got some tricks. We tried. So I said, the first thing I want to do is, we're going to assume some things. We're going to assume that there's this kind of secondary perpetual inflammation in the brain, which typically occurs after major brain injuries. So let's work on that. Let's see if this is a brain injury. Let's work on sedating inflammation, encouraging repair. They're like, you have something for that? And I said, yeah, we got a few things. They said, but we've been to UCLA, and we've been to the other local universities. We've been to the neurotrauma specialists, and they say, there's nothing for us. Either he's going to wake up or he's not. I said, well, I do voodoo. And I'm going to sacrifice some virgins and sprinkle some pixie dust, and I'm going to get my magic wand out. And let's just try some things. And they said, look, we're desperate. We don't care what you do. At this point, he's dying. We know he's dying. So went out to California, met the family, sat at the bedside, and we decided to start this nasal spray with him. I also started one other thing, just to be transparent. There's another anti-inflammatory called BPC 157,
Yes.
which stands for Body Protection Compound, and we had that made into a nasal spray as well. So we gave him just these 2 nasal sprays. Now, the RG3 nicotinamide, you can write for through PCCA, and then we also had them do the BPC. And they did it 3 times a day, high dosing. And a month later, Josh wakes up. Wakes up. And a month after that, he utters his first words, which was mama. Two years later, he's talking, he's eating, he's sitting up, he's responding to commands, he's getting his life back. He's beaten all the odds. It's extraordinary. So we see those things. And it's a privilege to do this kind of work. You will see these things. This is a special community, and one that if you really apply yourself, you'll be very proud to be a part of. So let's do a case. 15-year-old female, 3-year history POTS, so postural orthostatic tachycardia syndrome, complained of presyncope with standing generalized fatigue and muscle aches. She failed conventional medications. No other significant medical history. No medications, surgeries, or allergies. She was a competitive swimmer, unremarkable social history. No one knew why this was starting. Her parents brought her into my practice, and I said, POTS, it's one of these weird things. She had already been to the cardiologist. They did the tilt table test. They did, the standard medications. She still was very symptomatic, and no one knew what was going on. So we did some testing. She was somewhat inflamed, but everything else was essentially normal. And this was her cortisol curve. I said, And we dug into this history of stress. And she didn't have any. There was no emotional trauma. Nice family, nothing we could, we had a very honest conversation about, could this have been stress related? Was there some abuse? Was there some sort of event that occurred that she hasn't really processed yet? How did she get into this state? No one could figure it out. Seemed like a good kid from a good family. And I believed them. There wasn't anything there that kind of tricked my spidey sense. So we said, okay, let's flip over to the immune-mediated model. Maybe she's dealing with an immune threat. And sure enough, her mycoplasma levels were through the roof, and her EBV was somewhat high. I said, well, maybe this is what's going on. Maybe she's losing tone in her vascular system because of this. So I said, let's treat what we find. So we started Valtrex and azithromycin for the infections, gave her probiotic, of course, gave her a little tryptophan for mood, began her on the RG3 nasal spray, because we knew she was inflamed, the Sterilin, so that modulated her immune system, the theanine, and I also put her on the thymus protein extract. You don't need to worry about that. There's some literature on, it kind of supports the Sterilin. It's just to modulate her immune system. She probably didn't need it. So we killed the bugs, we decreased inflammation in her brain, we gave her something for her immune system, And we saw what happened. We said, are we right? You know, sometimes you have to use treatments as probes to know what's going on. And 6 weeks later, 6 weeks, she was symptom-free, and her cortisol levels came back up, magically, all on their own. And we said, wow, that was it. She had an immune threat. And if I hadn't sort of thought through that lens, I never would have gotten to these solutions. I never would have gotten to these solutions. And in fact, if I had just chased this and said, oh, I gotta do whatever I can to raise your cortisol, and I'm just, you know, I'm gonna give you some ashwagandha and some B vitamins and vitamin C and an adrenal cortex extract, and hopefully you'll feel better. She never was gonna get better with that, ever. So understanding how rich this piece of information was to me, and understanding the interconnectedness of various bodily systems was what allowed me to solve this Rubik's Cube. And this notion that if you understand how these pieces are connected, it allows you to kind of slip between different models and be strategic about your treatments and therapies. And when you can do that, when it's not just about the tools in your toolkit, but that transition of how you look at your patient, that's where the magic happens. That's where the challenge is, that's where the growth occurs for you as a practitioner. But when we take this kind of systems biology approach and we honor what's come before us in terms of the older ways of healing, and we respect the fact that they saw patterns within human illness, and now we have a way to overlay biological realities and measure those things objectively to guide us and give us guardrails, and we have much better treatment tools that are, I think, very interesting, like RG3 implants, sterolins, and the rest. You'll be able to do things with your patients that you weren't thought possible. And I think stress as a concept is a really nice way of kind of encapsulating that. Hormones and hormone replacement will fit somewhere within that model for you. And sometimes low hormones will be just the thing. That's it. They have low hormones, you give them hormones, they feel great. But sometimes a low hormone, like low cortisol, means something else. And over time, you'll learn, because you're gonna have patients where you do some hormone replacement and they get worse, not better. And their body is trying to tell you something else is going on. And if you really want to tackle it, you keep going, you keep learning, and you know, you build a bigger framework of how these shifts can occur and why they occur. So that's my sort of cautionary tale as well. And my challenge for you and my hope for you as a learner who's going through this, that get really good at hormone replacement, and you're going to learn even more about how that fits into a broader clinical model, you know, as you go through this process. And hopefully, the other thing we did today is take a concept that you thought you knew something about, and we expanded it for you. And we gave you a richness and an insight that you didn't have before. And as you get into this world, it becomes more and more fascinating. And so that's why I like to do this talk during BHRT. Hopefully it inspires you, keeps you going, and hopefully you too can see some of that magic. So thanks so much for your attention this morning. And I'll be back